And give me 1 second to share
Yeah.
mine. Okay. Okay.
Ja, we zien het.
All right, perfect. I don't know if it's too big, but hopefully let me know if some of it's cut off and I can go back to smaller. But so I am very glad to join today in this webinar. So thank you for inviting me. So I am an MZ as well, and I had something called intrahepatic cholestasis of pregnancy through all of my pregnancies, which is how I found out I was an MZ. And so I wanted to give a brief overview of ICP and its connection to alpha-1. So happy to go in more depth of this later, but we'll kind of go through kind of the surface level of this. So intrahepatic cholestasis of pregnancy is a liver disorder where the bile flow is disrupted through the bile ducts in the liver. So an intrahepatic disruption of the bile. So what happens normally is the fetus will make its own bile acids and the mom will eliminate those bile acids through her bloodstream through a diffusion from the baby to the mom. In intrahepatic cholestasis, the mom's bile acids build up in her own bloodstream, which leads to an elevation of not only her bile acids, but then the inability of her to filter out the baby's bile acids, which leads to buildup in the amniotic fluid surrounding the infant, the fetus. And so we'll go through kind of the complications of that. One of the misnomers is it is independent of gallbladder function. A lot of people think because you have the word bile that if you remove your gallbladder that you won't have cholestasis in future pregnancies. And this has been shown to be incorrect. ICP is solely a liver disorder. And we are still counted as rare, although I think maybe undiagnosed in several cases. If some of you think back to your pregnancies, you may not have known that you had ICP. We see a lot of people with other liver disorders that just didn't know that what they were experiencing was something they shouldn't have been. And so I think we're a little more common than we think, but right now we are a rare liver disorder. So multifactorial causes, basically there is some genetics involved. So we do see that ICP can run in families. A little more likely. So for those of you who are done with pregnancy, this might be important for your daughters to know, because if you had ICP or have MZ and pass that on, your daughter is more likely to have ICP. It has been linked to several different genes that are some of the bile pumps and the bile transit. So the ABCB4 and ABCB11 genes are known to cause at least 25% of the cases of cholestasis. We do also know it's kind of we think a two-hit hypothesis, if anyone understands that from cancer, where you kind of have a genetic predisposition, but then it takes something else to cause it. And so we do see that some cases of cholestasis only occur in patients when they do have an extra increase in hormones. So a mom might not have cholestasis in her first 2 pregnancies, but then become pregnant with twins. And that extra level of hormones is enough to kind of put her over into the stress and causing of the ICP. And then she might not have it in her other pregnancies. This also follows why IVF pregnancies with their exogenous hormones and the hormone treatments that you have to go through IVF, we see a higher risk of cholestasis. And this is also why it's mostly a 3rd trimester diagnosis when the estrogen and the progesterone levels are higher. I will say we do like to point out that it can still be diagnosed early. I myself had it as early as 4 weeks. And in an early case, there is a little more likely to be the genetic susceptibility. So we do recommend any of the early cases to get screened for all of the liver functions, including alpha-1. And then the other thing is there's thought to be a little bit of an environmental component to it. It's not really well studied, but it does seem that pregnancies in winter are a little more likely to have cholestasis, which is interesting. Some other things, selenium deficiencies, starting to look at vitamin D. But really, there's not kind of one cause of ICP. It's not like this is what causes it. We're starting to learn that there's maybe a couple different forms of ICP, a couple different causes of ICP, and that not all ICP acts the same. So much more to be determined on this. So the clinical presentation, mainly the one thing that patients have is itching. So this is how patients present. It is known in the literature as itching on your hands and your feet, between your fingers, rubbing your feet on the floor. But we find a larger percentage of our women, well over 50% of our women have generalized itching, so everywhere, full body. And it is usually worse at night. And it is usually not subtle. So it's not just, oh, I had a little itch. This is life disrupting itching. When we do surveys of our women, the ability to sleep is not there, the anxiety. They'll spend hours every night itching until they have scabs and bruises. And so it's really severe itching that affects their life during their pregnancies. Very rarely other symptoms. I mean, the fatigue goes along with the not sleeping due to the itching. Sometimes we do see a dark urine, but very rarely do you see jaundice in these patients. And then, as we said, cases can be early, but usually second to third trimester. So how you're going to diagnose it if you have a patient who comes to you and is pregnant and says they're having itching, your main test is going to be your total bile acid test. There are other bile acid tests that give a fractionated number, but that's really not necessary to know kind of which bile acids are elevated. Just knowing your total number is what you really need. So your bile acids are going to be elevated. And most of my talk is kind of I'm a US based OBGYN, but I'll kind of go through the differences between the US and Europe when there are main differences. So elevated bile acids, there's two different diagnosis levels. 10 is your diagnosis level in the US, and that was shown to be a level where the majority of normal pregnancies would have a bile acid level below 10, and the majority of pregnancies with cholestasis would be above that number. The UK uses a number of 19 as the findings. When you're between 10 and 19, the significant complications of the pregnancy are low. So you might be treating more people with this level of 10 that might not have had complications. And so they have gone with the level 19 for their diagnosis. Then a complete metabolic profile, so your measure of your liver functions. So measures the AST, the ALT, the bilirubin. So interestingly enough, liver functions are actually only elevated in about a third of patients with ICP. So really, that's our test. In the United States, unfortunately, bile acids take a while to come back. The UK is actually much better. But in the United States, you'll get your AST and your ALT back the next day, and patients will be like, well, I'm fine. But really, you're not going to see that elevation in a lot of the patients. So you really do need the bile acids for diagnosis. Bilirubin is also very rarely elevated. And then alkaline phosphatase is kind of a red herring here in that it's elevated in all pregnancies. So patients will often be, my ALP was elevated, and do I need to worry about that? That is actually made by the placenta. So we have a normal reference range in pregnancy that is higher. And then obviously when they have the itching, you want to go through their full medical history, see if there's any other testing you need to do. As we go through later, hepatitis C testing is important, seeing if they've ever had episodes like this before, and then a review of the medications, because there have been some medications that have been linked to onset of cholestasis. So you want to go through their history, obviously, when they present to you. And then this is just kind of, I throw this in here, fasting before testing, because this is a very interesting study from Mitchell. And basically, SMFM, which is the guiding board in the United States, came out and said you could test while fasting or you could test after a meal. And then after their guidelines came out, this article came out that showed if we tested while fasting, that 10 out of 11 women with the severe cases would not have been diagnosed as severe. And that will come in play later because bile acid levels drive the complications of the pregnancy. So we were really truly missing the true level of the bile acid elevation if we were doing these tests fasting. So we now recommend to our patients that they have their tests done after eating, and usually eating a normal meal is going to give you your most accurate results. So here's where we go through the risks of ICP. It's really actually, even though the mom is the one that's dealing with the itching and not sleeping at night, there aren't very many risks to the ICP to actually her. There is actually a little bit of an increased risk of gestational diabetes, so 5 times increased risk in ICP pregnancies. and then a slightly 2 to 5 times increased risk of preeclampsia, which is where you get elevated blood pressures, usually towards the end of the pregnancy. And both of these are actually seen as your bile acid levels get higher. So as your levels are over 40, those are usually the populations that we see an increased risk of the gestational diabetes and the preeclampsia. And then the other maternal risk of ICP is that there is a very high recurrence risk that you're going to have ICP in your next pregnancy. So 60 to 80% of women who have ICP are going to have to deal with it again. And this leads to a lot of conversations. We run a large support group of, family planning and can I go through this again? So that's a maternal risk that I would put on there, just the anxiety of the unknown with cholestasis. And then the risks of ICP. So the fetal risks are kind of more the ones we worry about and that moms who are pregnant worry about. We do see an increased risk in meconium passage, thought to be kind of due to the bile acids and the stress of the pregnancy, and it occurs much earlier than non-ICP pregnancies. Meconium in a non-ICP pregnancy is usually something with a post-term pregnancy. You see it a lot in your 40-weekers, 41-weekers, 42-weekers. But with ICP, you can see it as early as 34 weeks, where the baby will pass a stool while it is in utero, which has a risk of, at birth, something called meconium aspiration, where the baby breathes that meconium into its lungs. And it's also just a sign of stress. Early meconium passage is a sign that maybe the baby is being stressed in utero. We do see a higher risk of preterm labor. As we'll go through later, one of the treatments for cholestasis is to deliver early to prevent some of the stillbirth risks. But even if you take out the patients that we purposely delivered early, there still is a risk of preterm labor just on its own occurring, and mainly when bile acids are above 40. And then this is interesting because the function of this is very interesting. So respiratory distress at birth, all 4 of mine were NICU babies. And we do see that up to 20 to 30% of ICP babies will need admission to the neonatal ICU, usually for respiratory distress. So this is a lot higher, even in your babies that you don't deliver early, even in a 38-week ICP baby versus a 38-week non-ICP baby, you're going to have a much higher risk of that baby needing respiratory support. And they actually have looked at that some of the bile acids, especially the ABCB11 gene dysfunction, affect the formation of a molecule called surfactant. And that surfactant is needed after birth to kind of make the lungs be able to expand. And so those babies are actually missing that surfactant, or it's actually misfolded, so it's not doing its correct function. So it's very interesting that this is not just a disorder that's of pregnancy. We've started in our institution, anytime we have a cholestasis mom in labor, letting our neonatologists know that there's a high risk that that baby might need support. And then the big scary thing and the reason why we all advocate and educate about ICP is the risk of stillbirth. So the mechanism of stillbirth in ICP is still being figured out, but the latest is that it most likely is an effect to the fetal cardiac conductivity. So the bile acids have been shown to prolong some of the like the QT window in the baby. And so this is a sudden event. You can have a baby that is on a monitor, looks great, goes home, and unfortunately has this cardiac event. So unfortunately for those of us with cholestasis, this is hugely anxiety provoking because there's no way to know if your baby is going to be one of the ones that happens to or doesn't. So there's no way to predict it. There's no way, besides we'll go through bile acid levels, but other than that, there's no way to reassure yourself during your cholestasis pregnancy. So that is kind of the big thing we all worry about in these pregnancies. We do know that the risk of the stillbirth does follow bile acids. So this came from a lovely, lovely study. If you want to read one study about cholestasis, I would read the Ovadia study. So this was our first big look at cholestasis pregnancies. Prior to this, it had been a lot of case studies. These 12 patients, and oh, look, if they had hypothyroidism, their baby was a little more likely to have a stillbirth, which but wasn't able to tell us anything concrete, really. So this was our first paper that actually gave us really concrete evidence of who we really needed to worry about more. So they took 5,500 cholestasis women from throughout the world. So this was a meta-analysis from a large number of institutions, and they found that really you need to worry about those women with a level of bile acids 100 or greater at any point in the pregnancy. So those are our women who are having the stillbirths. That risk was 3.44% of the women with bile acids over 100 would end up with a stillbirth. And you compare that to a stillbirth risk, I just used US data. In a non-ICP pregnancy, your risk is 0.33%. So 3.3 out of 1,000 pregnancies. So your lower levels actually for stillbirth are under the level of a normal kind of non-ICP pregnancy. So your levels under 99, you still need to obviously treat them with active management, but you can kind of rest assured that they're not as high risk, and you really, really, really want to make sure you target in our support groups. We make sure anyone who has a level over 100 that we as a moderator kind of contact them and say, just so you know, we want to make sure you're getting appropriate care, because those are the women that are unfortunately having the stillbirths. So there is one medication really that is the gold standard to treat. So it's called ursodeoxycholic acid. So it is itself a bile acid that is thought to replace the more toxic bile acids as you go to water soluble, not water soluble. So this one is thought to help the elimination of the non-toxic bile acid, or the toxic bile acids, and replace them with this ursodiol. So they have done more studies in the lab that have shown that the ursodiol was able to actually protect the fetal heart cells from the changes that were induced by the bile acids, that prolonged QT interval. Aging of the placenta is also thought to maybe contribute to the stillbirth. So these ursodiol was thought to limit the early aging of the placenta that we can see in cholestasis. And it was also actually able to correct the placenta's ability to then transport those bile acids that the baby was making away from the baby. So lowering the mom's bile acids, allowing those baby's bile acids to transport and be eliminated. So there's a lot of kind of out there about ursodiol. Unfortunately, we did have a study come out called the Pitches study in 2019. And this was the gold standard study because it was a randomized control trial. So it compared ursodiol to placebo, looking for a difference between the groups, and was not able to show that there was a decreased risk of stillbirth in pregnancies treated with ursodiol. Now there is a question, obviously, with a stillbirth being a rare event. Luckily, there's questions of power and whether study size, but the conclusions from the study, we cannot conclude that a mom being on ursodiol is going to completely eliminate her stillbirth risk. So this was kind of a big blow to the ICP community, because it's nice, you think, I get diagnosed, I get on a medication, I'm going to be one of the ones that is safe. And unfortunately, we cannot say that. And so that's why the other main portion of treatment is equally as important as the medication treatment. And that would be what we now call properly timed delivery. So this has been changing a little bit over the years. It used to be where we thought 36 weeks was the best for all babies. We've actually, since the Ovadia data, realized that if stillbirth risk is driven by your bile acid numbers, that we should be using our bile acid numbers to guide our delivery. So those bile acids over 100 need to deliver at the latest at 36 weeks and 0 days. And that is a kind of a conservative that you probably should not even go that far. So the UK data is delivering most of their babies at 35 weeks with levels over 100. And the reason is that stillbirth is known to cluster towards the end of the pregnancy. And so the thought is to try to get the baby out before that risk truly elevates. And so 34 to 36 weeks is more accurate for the bile acids over 100, especially if they're not lowering with medication. There seem to be some people that respond to ursodiol and some people that don't. And so that needs to be looked into further. But if your bile acids are staying high, you definitely should consider delivery as early as 34 weeks. The bile acids with between kind of over 40 and 100. Delivery is between that 36 to 39, but strong consideration for the earlier portion of the window. And then your bile acids that are low can deliver up to 39 and 0.7 weeks, but we feel this should be a strong conversation with your physician about the risks and balancing all of that. So an independent conversation with your physician. That's why they left the windows kind of wide to allow different people. We have women who have very different feelings about some are just deliver me now. Some are like, well, I'd love my baby to avoid the NICU. So it's always a balance and a personalized decision, but higher bile acids deliver early to prevent that stillbirth. And then I will get into why we're talking about this today. So ICP can often be the first sign of an underlying liver disorder, including alpha-1. So this is kind of my chicken and my egg, right? So a lot of people, it's hard to explain sometimes that the ICP is more unmasking the other liver disorder. A lot of people think I had ICP, and if I get pregnant again, I'm going to damage my liver further, and the ICP is causing this. And actually, the more we learn about ICP, the more we think that the ICP was actually caused by something else. So something else predisposed a portion of women to have the cholestasis. So kind of like that two-hit hypothesis, you were predisposed to it. The hormones of pregnancy caused the ICP. So this ICP, and in talking a little bit, sometimes women are diagnosed earlier with alpha because they had the ICP. So the ICP is first sign that there is an underlying liver disorder. And some of these disorders, other disorders besides the alpha-1, would be autoimmune hepatitis, your cyclic itching syndromes, which these are really hard to diagnose anyway, BRIC and PFIC. So these are familial cholestasis syndromes. Your primary biliary cholangitis, PBC, your primary sclerosing cholangitis, and then Hep C is actually linked. There are several good papers out there on Hep C and increasing your risk of ICP in pregnancy. Currently, we think that underlying disorders are more common in patients who were diagnosed early, so before 28 weeks of gestation, or in cases that were considered severe, so bile acids above 40. So those cases definitely, and this has just come down in the last 3 years, that we're now recommending to be followed after pregnancy with some levels. So that's kind of just, this link is just starting to kind of be known. We used to say, your pregnancy was over and you don't need to worry about anything anymore, but now we know more. There is one study out there really that has been found. So on alpha-1, and Franz talked about this a little bit, but so in the study of ICP patients, basically they had, sorry, I talk about the study a little bit later. So this study, so they looked at 103 patients who were already diagnosed with ICP and then tested them for the alpha, and a higher than average were noted to be MZ than you would expect from the number of, out of 100 patients, you wouldn't expect that 6.8% of them would be MZ. You would expect more than 2 to 3%. So this was higher than expected. And as I will say here, you cannot make anything statistical from these, but just going through the data and the appendix of the study, it was interesting to see that we need to look much more into this, into like the severity and looking at, is there more severe disease in the MZ/MS? Now, unfortunately, this obviously N is 5,500, this N is 8. So you can't really conclude anything, but I thought this was very interesting that 25% of your population of the MZs had levels over 100. So I think there is so much more research needed in a combination between ICP and alpha and the groups. Does alpha-1 MZ lead to more severe ICP? And then I know Sally brought up a question before we started our talk about hormones and what happens in MZ patients if they take hormones. And this is a largely undiscovered area that we're starting to look at. Birth control, hormone replacement, all of these things. We know that ICP patients who take birth control are more likely to have recurrent itching. And so is that the same for the alpha population? Much, much more needs to come as far as this goes. Other health concerns of ICP, gallstones, so very common also in the MZ population, gallbladder inflammation, cholecystitis, pancreatitis, and then fatty liver. So these are all probably very similar to the driving factors that drive them in the MZ population, but we do see these a lot more common in patients who have a history of ICP. Hypothyroidism has actually been linked. So an autoimmune hypothyroidism is increased in patients with a history of ICP, and then they're looking currently at the possibility that other autoimmune disorders may be linked in ICP patients. Good news is offspring of ICP moms have been looked at. I didn't go through this. We go through this on our webpage kind of extensively, and not very many concerns for the offspring from a pregnancy with ICP. So that is reassuring. Obviously, if your mom is MZ, you'd want to look into your children. So, and then as thought, so people think the ICP pregnancy caused my gallbladder to act up, but again, it's thought to be the same genes that caused or predisposed you to the ICP also are known to cause these other disorders. So it's not that the ICP caused this, it's that the ICP was just a sign that you had this going on. And then I just plug, I am part of a patient or advocacy organization in the United States, so icpcare.org. And we have a website that goes through kind of everything you could ever want to know about cholestasis. We have both a provider website, which goes through the latest research, is definitely evidence-based, and then we have a patient-facing side for easy information that you can read. And then if you want to read more in depth, you can go into the provider side and get all of that. And we are also enrolling a patient registry for patients who had an ICP in their pregnancy. We actually do have a couple alpha MZs in there. So if you did have cholestasis in your pregnancy, we would love to have you. It's all patient data right now, so patient survey data with the possibility of doing medical records in the future. So yes, that is me. And then I have just my reference.